All right, so I want to welcome everyone to what I think is one of our most exciting grand rounds of the year, a day that I look forward to every year, and where we get to hear from each of our chief residents about how they spent their R5 year. And it's really serves as a culmination of all the hard work that they put in during that year and also over their entire careers with us here at UCSF. So, as many of you know, or all of you know, that UCSF this is really distinguished in a lot of ways as being one of the only programs that still has a fully funded research year. It's part of what makes us special and who we are. And it's a strong commitment that the department makes, really to teach the future leaders of urology, which we have here today. So the R5 committee consists of a bunch of people who work behind the scenes, and I want to acknowledge all of them. So myself, and many of them are here, David Quigley, Annabelle Odishu, who's sitting right here, Hal Wen, Carissa Chu, who's up here as well, Lindsay Hampson, and we're supported by Karen, who I think just stepped out of the room. And the team works alongside our residents throughout the R4 and R5 years and does several check-ins with the residents throughout this time period, one-on-one coaching, and also mentorship meetings with the whole team. So I want to also acknowledge all of our faculty members and mentors who this would not be possible without. Our mentors are really fabulous. They not only spend a lot of time and energy, but they give a lot of themselves, their resources, and they really make this experience what it is. So we are very proud of each of our residents, Mika, Kevin, and Jorge sitting here. And each of them will be introduced by one of their mentors. So I'm going to turn it over to Christy, who's going to start off by introducing Mika. Thanks, Christy.
All right, we're going to kick it off with Dr. Mika Chang. It's my pleasure to introduce Dr. Mika Chang, one of our urology chief residents. She is no stranger to UCSF. She's completed the UCSF Berkeley joint medical program before continuing on to her residency here. Mika has always been deeply dedicated to providing the best possible care for her patients and improving patient outcomes. That commitment extended into her research year, during which she was mentored by Dr. Van Kijken and myself on projects focusing on improving patient education and utilizing the AQUA database to better understand outcomes for patients with overactive bladder. Her work was supported by a CUF grant and has been presented at numerous national meetings, including SUFU, SWU, US PATH, and Trans Health National Conference, and the AUA. On a personal note, Mika has had a tremendously positive impact on my patients' experiences in the clinic and helping them navigate the path to surgery. Please join me and welcome Dr. Mika Chang as she presents her research.
Okay, thanks everyone for making the trek out to Parnassus today. Today I'll be presenting Lights, Camera, Care using video multimedia to improve the gender-affirming surgical experience. As we all know, gender-affirming surgery encompasses many complex components in terms of intraoperative steps, postoperative care, and psychosocial considerations. From my experience during mini chief year at Parnassus, working with patients undergoing gender-affirming surgery, I knew I wanted to spend a part of my research year exploring the current state of preoperative education for these patients, as I believe that this is imperative to preventing complications and improving outcomes. Our qualitative study aimed to explore the patient perspective of opportunities for improvement of preoperative education for gender-affirming bottom surgery. We conducted semi-structured qualitative interviews with patients who had undergone gender-affirming surgery at UCSF between 2023 to 2024 using purposive sampling, and transcribed and coded interviews using thematic analysis. Data were analyzed to identify recurring themes that could then be developed into patient education interventions. We were able to conduct a total of 11 interviews during the summer of 2024 with patients who had undergone gender-affirming surgeries, including metoidioplasty, orchiectomy, vaginoplasty, and vulvoplasty. The actionable themes that we discovered during these interviews, including revamping the vulvoplasty and vaginoplasty binders, which are a set curriculum we provide every patient prior to surgery, disseminating tailored information in a variety of multimedia formats, particularly video education, providing more resources for caregivers, improving access to patient testimonials and peer navigators, and also providing more details of the surgical steps and post-operative anatomy for patients and caregivers. Some challenges that patients identified were interpreting health insurance coverage for their surgeries, obtaining hair removal prior to surgery, navigating post-operative hormone management, and the physical and emotional fatigue experienced during recovery. Despite these challenges, most patients were highly satisfied with the care they received, emphasizing the professionalism and cultural competence of the staff. In conclusion, while current preoperative educational resources prior to 2025 were generally well received, there was a desire for more multimedia formats, particularly videos for both patients and caregivers. So from these actionable themes, we then chose a couple feasible interventional targets that we could address within 1 year. The first one was addressing the conflicting information in the current resources or the binders. And then the second part was to provide video education on surgical anatomy, what to expect prior to and the day of surgery, and general post-operative recovery expectations. The first part, supposedly the easiest part, was updating the 89-page vaginoplasty binder to current practices. Then we worked with some medical student volunteers who had backgrounds in medical illustration, along with a video content creation company to create an animated clip to visually explain how anatomy changes during this complex surgery. Here's the final video we created showing the surgical steps to gender-affirming vaginoplasty. As you can see, there's no time here, but it's about less than 45 seconds long. However, I think cumulatively to create this clip took over 50 hours of work, including original drawings, converting them into illustrations, Zoom conferencing, piloting, several different drafts. It was quite a humbling process that truly required collaboration from several different disciplines to merge our skill sets into one accurate yet understandable video for patients. The next phase of the project was to create a comprehensive video narrated by Dr. Christy Butler that we could send to patients to better equip them prior to their initial consultation with her. This was a sort of flipped classroom that patients I had come up with that could then allow for the consultation to be more personalized and involve question asking rather than spending time on the same basics every session. It was also a way to provide a resource that patients could then watch over with caregivers or families who may not be able to attend these initial consultations due to work or other responsibilities. I won't make you watch the whole 20-minute video, but just some highlights, an introduction to Dr. Butler, some evaluation that we require before surgery, mapping out where they need hair removal, different surgeries that are offered.
Note that there are 2 different approaches to vaginoplasty offered here exist.
Some normalization of different types of anatomy they may see post-op.
Vaginoplasty includes
just going over the surgical steps.
Extracted from the tissue of the
The video that I showed you earlier, but narrated so that patients could follow along more easily.
Now about the peritoneal approach.
Again, different options. We even talk about prostate cancer screening for transgender women. Oops. And then some risks and complications, common wound locations, just to provide patients better expectations for post-op. And then also some post-op requirements, and just generally providing a timeline so that patients had a better understanding about this complex process. The last and third part was discovered through patient interviews that patients thought that the day of surgery was really quite overwhelming. It was hard to find the preoperative area. They were meeting tons of providers the entire day and not understanding the roles of each of these providers. And a couple of them came up with this idea, which we then adopted into a day of surgery video for patients to get to know the very large perioperative team involved before the patient even arrived to the hospital. And you can see some familiar faces here. The creation of this video is also extremely humbling, being able to capture quality audio, video, juggle the lighting and the background noise, edit the clips. We had really great actors, but it was difficult, to follow scripts and film the scene in one shot. So this was also a really brand new skill set that I developed on the job. So we showed, how to get into Parnassus, where to find the pre-op area, Mission Bay as well. We did some care team provider intros with perioperative nurses, anesthesiologists, Dr. Butler, some more nurses, inpatient nurses, Melanie, who we miss dearly, and then also some familiar resident faces. So far, patients undergoing bottom surgery here have really positively responded to these interventions and have generally felt them to be helpful. The next phase is really to evaluate whether patients feel more ready for surgery now after a year of these interventions compared to previous cohorts who we had done some quantitative surveys with. So if anyone's interested in that project, please reach out. This was only a small component of my research year. I also got to participate in a huge aqua overactive bladder project with Dr. Van Kijken that we presented all over the country. I got to spearhead the SFGH QI project, where we brought clinic after visit summaries in different languages to patients for common urologic conditions, participated in some courses all over the country, presented at conferences, celebrated one of my dog's 10th birthdays, raised a puppy from scratch. I'm really proud of being able to interview and negotiate for the first time for my first real job out of residency, and signing with a group that I'm really excited to start with. Jasmine and I got to congratulate the 5th year of Ureter mentees matching into urology, which we're really proud of. And also I got to celebrate my 5-year marriage anniversary in Paris. Here's some photo highlights from a conference, baby butter. I finally got to get on Dr. Baskin's boat, but still waiting for Dr. DeSandro's invite. Here's some of us at SWU. Here's my husband graduating plastic surgery residency. Here's Dr. Van Kijken and I receiving an award and presenting at AUA. And this is Jackson's birthday and our 5-year wedding. And then the most important slide, I'd really like to thank, we'll send out a major love letter and huge thanks to everyone listed on this slide and beyond, particularly the study participants and all the studies I got to participate in last year and this year. Christy Butler for mentoring me throughout the year and beyond. Michelle Van Kijken for mentoring me both in the OR and during our project. Anne Suskind for doing all of our meetings and really helping me with the negotiation part of my year with my new job. Thank you so much for all your tips and advice. John Lindsay for being my forever county chief and my go-to andrology advisor. So thank you. Seema Portin for all the splurge mentorship dates you've taken me on and all the advice you've given me in and out of the hospital. Our wonderful medical students we worked with, Ariel, Maria, and Rachel, who have really bright careers ahead of them. If anyone's looking for a medical animation group, Satyen Rao was amazing. This is his website. And then especially all the providers who volunteered their time for the day of surgery video, and then my husband, Justin. That's it. Thank you.
Okay, I have the distinct pleasure of introducing our next speaker, Dr. Mena. He'll be giving a talk on needs-driven innovation, the biodesign methodology applied to spasticity management. Thank you.
All righty. Can't see it up there. Great. All right. Well, thanks everyone who was able to make it here in person today. I know it's not easy to get across in the morning getting into Parnassus, but also thank you so much to everyone who's online watching. As you all saw, from the intro, I'll be talking a little bit about my year and how I spent my time at Biodesign last year. No disclosures. When I spoke with people last year and I talked about what I did last year, I feel like this is what a lot of people probably thought I was doing. It's like, or is just down at Stanford creating the next big tech company, but that's quite far from it. So I want to tell you a little bit first about the Biodesign Innovation Fellowship and what that entails, because that's really what the bulk of the work was, but then also get into my project and how we applied that methodology to spasticity management specifically. So what exactly is the Biodesign Fellowship? So Biodesign is a big institute. However, the crown fellowship is the Biodesign Innovation Fellowship, which happens every year. It's a 10-month intensive, full-time, team-based fellowship. You're there every day, Monday through Friday, sometimes on weekends. There's 12 fellows that come in from all over the world. In our year, we had people coming from Spain, some people from China, and a lot of people from the US, of course. There's a combination of clinicians, PhDs, engineers, with the goal of basically making very cohesive teams with different expertises that can complement each other to ultimately come up with great ideas and products. There were 4 teams total every year. So there's 3 teams of 4 people. And throughout the year, like I mentioned, we had all these sessions, workshops, and we interact with over 100 instructors that are there specifically to teach us across the clinical setting, scientific aspect, but also about engineering, manufacturing, and learning about the regulatory pathways from both from intellectual property, legal, and ultimately, when you get to the final point, how do you really make this idea that you came up with an actual business? The process itself is divided in 3 stages: the identify stage, the invent stage, and then the implement stage. The identify stage, really, it's where we spend a lot of that bulk time in the first 3 months, where we perform what we call what's known as needs finding, and is one of the key things about the biodesign process, which is a needs-driven innovation process, where it's we're not coming up with oh, I have this great idea, let me just make a device and I'm going to go sell it. People are going to want it. It's really about hey, let's go into clinic and see what are the problems that patients are facing, and then let's try to see which of those problems are worth solving. We spent 5 weeks in the clinic, in the operating room, outpatient facilities. And for our year, our specialty was physical medicine and rehabilitation. On 4 years before I did biodesign, a great John Lindsay, who also did this program, he got lucky. He got urology, so he had a leg up. And the stuff they came up with was really cool. I was oh wow, I don't know a lot about PM&R. I feel like we got nothing in medical school, and I thought a lot of the stuff that PM&R does was physical therapy overlap, which it is, but they have very unique set of skills, and they actually there's a lot of big needs in that area. So something that I thought would be a disadvantage for me was actually a huge advantage, because I was coming into the clinic not really understanding what were the preconceived biases and notions by PM&R physicians. So I was able to really look at things and be like, why are you guys doing this way? I feel like a lot of times one of the things as urologists, we might be used to do something in a particular way and we don't see it as a problem, but to an outside observer, they're like, it's like so inefficient. And that might be the thing that really changes practice. So when we identify those 300 needs in the clinic, then we go and take them through a very rigorous process to filter, because clearly we cannot make 300 products or devices or companies. Each of them takes about 10 years. So we basically looked at 5 different filters around the areas of patient impact, provider impact, market size, solution landscapes, and mechanism of actions. These are the filters that really help us determine like, what is it that we want to focus on? Because like there might be a problem that you think is a really big problem in the patients that you see all the time. But the reality is like when you look at the broader picture, there might be a lot of solutions already out there for it. It might affect a really small number of people, or you might have a very complicated mechanism of action. You're not going to be able to solve that problem realistically. We apply all those needs to all those filters to our 300 needs, and we ultimately come out with about 4 needs. Once we reach those needs, then we can actually get into the invent phase, which I think is the most fun part, because this is where you really get to like brainstorm and like really build your solutions. So we do this, and when we go into it, we really want to be solution agnostic. We sit down in a room and we basically are like, all right, this is the problem that we're trying to fix. Like we got to come up with as many solutions as possible. Even if it's crazy, just go out there and like, let's think as broadly as we can. And then from then we can narrow it down by concept generation and concept screening. The solutions can be anywhere from something like an app or a digital health solution to a biotech solution or even a medical device or a combination of either of these 3. The concepts, like I said, we usually start with multiple concepts. Sometimes it can be really crazy. And then we ultimately start narrowing down, looking at intellectual property, regulatory pathway, business models, and ultimately feasibility of being able to create some of these concepts until we get to our final concept. This was my team. It was made of 4, like I mentioned, 4 team members. Jens was from Switzerland. He's an engineer from Switzerland. And then Marissa and Shireen were both from the US. Marissa was an engineer, and Shireen is a cardiology fellow at Cedars-Sinai. So how do we apply that to our specific project? Like I mentioned, we were getting all these lectures throughout the year and these workshops, but at the same time, we were working and applying what we were learning to our specific project. When we were in the clinics and the different PM&R clinics, one of the things that really jumped out at us was the problem with spasticity. We saw a lot of patients in cerebral palsy clinics and also patients in like rehab facilities and basically SNFs that we were visiting that were dealing with this problem. So for those of you who might not know spasticity, I'm sure we've all seen it, but it's usually caused by an upper motor neuron lesion, in which like leads to an imbalance in excitatory and inhibitory signals and leading to extreme muscle tightness. And then over time, that leads to many complications. In the US, over 2.1 million people are affected, and any of these diseases can lead to spasticity. From a cost standpoint, it's a huge burden on the healthcare system and on patients. There is no cure for it, and we just really have to manage the symptoms, which is costly to patients in the healthcare system. And these are some of the things that we do. We do surgery, we place patient orthotics, a lot of physical therapy, but also we give them drugs on a regular basis. And the spend is like really high, upwards of 3.6 billion. There's no great solutions for spasticity. Like I mentioned, we have things that are very basic, like some pills that you can give that can manage the symptoms to some degree. There's like a lot of the other things such as like Botox, which we're very familiar with for our own patients. But then you have very invasive surgeries that involve like opening up the spine and cutting down certain nerves, or even placing baclofen pumps, which I'm sure we've all been consulted from patients in the emergency room, that can be very problematic and have a lot of side effects, despite the fact that they do work when they work well. We focused on medication. We noticed that like a lot of the patients that we spoke with had a lot of issues. They were taking these medications that were specifically acting on the brain and the spinal cord to reduce their muscle tone, but at the same time, they were dealing with pretty terrible side effects. However, these were the only medications that are out there for it. Like I mentioned, these are effective, and when they reach their target, they work really well. But the most common way to give it is a pill, and sometimes that leads to poor penetration into the CNS and also high systemic exposure that leads to high fluctuations in the peaks and cause really debilitating side effects. And then you guys might have been familiar with the baclofen pumps, which work really well once they're in there and they get the medication to the brain and spinal cord. But very invasive surgery, very frequent complications. So when we were looking at the subsegments of the population, we saw like, you know what, there's a lot of people with spasticity, but there's this group of 1.1 million people that have moderate and severe spasticity that are taking these meds. So we were, how can we help them? And we basically came up with the fact that there's a clear need. We need a non-invasive way to treat the systemic spasticity in patients that have upper motor neuron syndromes to improve their quality of life. And one of the things that we landed on after really running through this whole process was a better way to deliver drug to the CNS that avoided the systemic exposure. And with research that we conducted, we came across the fact that a lot of people, a lot of advances in technology have now been focusing on delivering drugs via the nose. And I know a lot of us are familiar with drugs that are delivered via the nose because, and the reality is like most of those drugs actually just get very high exposure to a wide surface area and avoid first pass circulation. What we wanted to focus on was slightly different because we wanted to avoid systemic exposure, but really get high levels to the CNS. And we came across the fact that there are olfactory pathways that completely bypass the systemic circulation and go through the trigeminal and olfactory nerves to get into the CNS. So that's what we wanted to exploit. And we wanted to create a drug, a product that would be higher efficacy, would have a reduced side effect profile, and be completely non-invasive. And that's what we spent a lot of our time on. We use an epithelial barrier model initially to screen several drug candidates in the lab for their nasal permeability. And this was all done in vitro. And after we identified some novel candidates, we actually were able to show that we could achieve higher uptake in the epithelial barrier compared to a standard of care therapeutic. And this was all done in vitro, upwards of 50 times the dose that's typically achieved when you give something without the modifications. At the end of our program last year, we were able to achieve funding from the Johnson & Johnson and the Valhalla Foundation, which was a lot of basically what we use in order to continue our project over this past year. Of course, I've been a chief resident and I haven't been able to make many trips down to Stanford, but my team has been working quite hard. And there are some of the things that we've been doing. We conducted a really thorough screening of multiple agents. We were able to hire a synthetic chemist, and we were working with the medicinal chemistry department at Stanford in order to synthesize and screen a bunch of compounds, which after conducting our in vitro studies and selecting some a more narrow list, we were able to take this to in vivo studies in rats. And this was something that we initially had planned to conduct ourselves, but we quickly realized that it would be a lot easier if we could outsource this to a CMO facility. And those results are very promising. And we're hoping that once we have further explore additional candidates, we will be able to basically conduct hopefully some further studies and early clinical trials. Beyond research here, I think some of the things that I really take is that this is really more than research here should be more than just a project, and it should be more about a framework. I think we live in a ever-changing landscape of medicine and technology. As we see, we're at a very privileged spot in the Bay Area where right now we're getting to see AI, and I think we're every year there's more and more capability of what we can do with different technology. And I think one of the things that I take from this program is it really taught me less about oh, here's how you make this device, but it's more about this is how you really identify problems that matter and that are worth spending your time and effort on. And now with all the advents, I mentioned, with new technologies, I think the possibilities are truly endless. So I would encourage anybody who's interested in this type of work to really explore something like what I did. I'm very interested in applying the Biodesign framework to urologic needs. Next year, I'll be going to endourology fellowship down at Stanford, and I'm hoping to continue a lot of the work from Biodesign while I'm there. But ultimately, as I look forward to a career in academic urology, I really do hope to continue applying this framework for my research, but also for teaching, because ultimately, sure, I can get out there and I can try to do work on some projects, but I will be limited in my time and how many projects I can work on. But if I can teach the process, then I can teach it to 10 people, then we can really expand what we're able to achieve. So I'm very excited for that, and I'm very thankful to all the people that supported me last year. Olivia, of course, was my baby mama. No, my fiance, soon to be wife, but also we're expecting a little baby in July, so I'm very excited for that. And of course, everybody here in the department. Yeah, thank you, everyone.
Okay. On behalf of Dr. Nguyen and Dr. Carroll, I'd like to introduce Dr. Kevin Shi. This is written from them. It's my pleasure to introduce Dr. Kevin Shi, our UCSF Chief Resident, whose last 5 years of scholarship has been nothing short of extraordinary. Kevin has established a research record that already reflects the caliber of a junior faculty investigator with over 120 publications and presentations, including 62 peer-reviewed manuscripts with 35 as first author. His work has shaped how we understand active surveillance, HIFU outcomes. I don't know if it's PI3 or PL3, I'm sorry, I'm not an oncologist, kinase-resistant prostate cancer and kidney stone disease, and he has repeatedly earned top honors at AUA, Western Section AUA, SUO, and our own UCSF scientific retreats. Kevin's research has been continuously supported by competitive funding, including the AUA Resident Research Award, multiple CUF grants, and most recently the UCSF Prostate Cancer Program Pilot Award. Beyond the numbers, what stands out is his clarity of thought, his rigor, and his ability to translate complex data into clinically meaningful insights. Please join me in welcoming our final Chief Resident, Dr. Kevin Shi, as he presents the culmination of his research as Chief Resident.
Thank you, Dr. Butler, and thank you remotely to Dr. Nguyen and Dr. Carroll for that really, really overly generous introduction. Thank you all for being here. I'm really excited to talk about our outcomes data here that we have available at UCSF, in particular regarding our work on active surveillance for prostate cancer. So just to get right to it, just to talk a little bit about active surveillance for everyone who is not aware, this developed as a response to concerns about overdetection and overtreatment of prostate cancer due to widespread PSA testing, where essentially every patient that was being diagnosed with prostate cancer, no matter what type, was getting surgery or radiation. The goal of active surveillance is to avoid or delay cost of treatment without compromising cure, and the way we do that is through very accurate monitoring. And we have a scheduled armamentarium of tools for active surveillance. And we have blood testing, so the PSA adjacent tests, imaging, multiparametric MRI, and now micro ultrasound and biparametric MRI, tissue sampling with systemic biopsies and targeted biopsies. And then the new frontier is genomic testing, and there's really been an explosion of work in that field. Active surveillance is really about timing. And so the question that we always want to ask is, does this prostate cancer patient need to be treated right now? And it is endorsed by NCCN and AUA guidelines as the preferred management strategy for low-risk prostate cancer and is an option for select intermediate risk patients. So to talk a little bit about active surveillance and how it works at UCSF, it is really important to note that it is tailored to the individual patient here. There's no set defined protocol for every patient that is under active surveillance. It is shared decision-making between the patient and provider, and just generally consists of regular PSA blood testing, a mandatory confirmatory biopsy within 12 months of their initial diagnostic biopsy, a prostate MRI imaging and targeted biopsy every roughly 2 years. And here at UCSF, at least, nearly every patient gets a genomic test. The general rule of thumb is that lower risk and more stable cancers can get less aggressive surveillance, but that is certainly not the case with every patient. And this is all just kind of dependent on the conversations between patient and provider. So the determinants of active surveillance eligibility, these are the traditional ones that we all know about. In red is the low risk cutoffs, and in orange is the favorable intermediate risk cutoffs. But PSA density, volume of prostate cancer based on core positivity, stage based on exam or imaging, and pathologic grade. And so I'll use Gleason 3+3 and grade group 1 interchangeably, as well as Gleason 3+4 and grade group 2 interchangeably. More recently, the importance of MRI positivity, high risk versus low risk genomics, and adverse pathology features such as expansile cribriform and intraductal carcinoma are increasingly important. And we also really take into account patient's age, health, life expectancy, patient and family preferences, and more. So this is a really nice study by Dr. Cooperberg recently, and the gist is that uptake of active surveillance is increasing nationally, but at least in our eyes, there's a lot of work to do. This is a study using the AOA Aqua Registry, which is a multi-institutional study looking at grade group 1 prostate cancer and uptake of surveillance nationally. And this is from 2014 to 2021. Active surveillance in this cohort of patients increased from 27% to 60% over that period of time. We'd like to see that closer to 100% here at UCSF, but it is certainly progress. Just to talk briefly about our outcomes specifically at UCSF here, I'd like to just highlight the urologic outcomes database that we have available. And really just want to highlight Dr. Carroll and his leadership and vision that he's had for prostate cancer research over the past couple of decades. He had the insight that data is power, and if we can collect that early and rigorously, we can really make a difference for answering key questions for prostate cancer. And so currently our UODB is one of the largest institutional databases in the world. We have over 9,000 prostate cancer patients that have been seen and treated at UCSF over time. In general, the majority of these patients received radical prostatectomy, but we have a large number of patients in our active surveillance cohort. And more recently, we've added focal therapy patients and their outcomes data to this database. I'd also like to give a shout out to Janet and Lufan, who are our two primary statisticians who work with this database, without whom none of these projects would be possible. So to talk about grade group 1 prostate cancer, which is the traditional low risk type of prostate cancer, we recently published our series, like an updated series last year in European Urology Oncology, and we had 1,400 patients on active surveillance with confirmed grade group 1 prostate cancer. So this is diagnostic and confirmatory biopsy showing Gleason grade group 1 prostate cancer. And there's a lot of additional analyses in this study that you can look at if you look up the paper, but I just like to highlight this life table estimate figure from the paper to really just show what our outcomes look like at 10 years of time. And so just from top to bottom, the various outcomes we looked at: upgrade to grade group 2, major upgrade to grade group 3 or greater, metastasis, and survival outcomes. And I'm just going to highlight these 10-year outcomes, but upgrade is nearly 60% at 10 years, major upgrade about 19%. But importantly, metastasis only 2% at 10 years, and there's only one event out of the 1,400 patients for prostate cancer specific mortality. So our takeaways is, even though there are high rates of upgrade and moderate rates of major upgrade, the very low rates of metastasis mortality mean that surveillance is safe in this cohort as long as they're being surveilled appropriately over time. Looking at grade group 2, which is a more controversial topic and is just a more recent question, we just wanted to see if active surveillance was safe for these patients. And so we did include, for our inclusion criteria, it was a selected group of grade group 2 prostate cancer, so what we would consider more favorable risk, meaning less than 50% of their cores were positive for grade group 2 prostate cancer or prostate cancer in general, and they did not have adverse pathologic features. We identified 329 patients in our cohort that had confirmed grade group 2 prostate cancer and were on surveillance. And these are what the outcomes look like for 10 years. And they look somewhat similar to our grade group 1 series, actually. So upgrade to grade group 3 or greater was around 60%. And just I'll skip to kind of the bottom there, but 65% of patients at 10 years did undergo some form of active treatment. And in this study, it was defined as either progression to focal therapy, radical prostatectomy, or radiation therapy plus ADT. And then 3% of patients went on to develop metastasis at 10 years. And this is just kind of in comparison to the direct numbers from the GG1 paper, where it was 20% for the upgrade to grade group 3 or greater, and then 30% active treatment and 2% metastasis. And still in our minds, because of these low rates of metastasis, as long as the patients are well selected and being monitored accurately, there is a high rate of upgrade for these patients, but we do believe active surveillance is still safe. And at the end of the day, it may end up coming down to things like life expectancy, but these are numbers that you can cite to your patients, at least for patients that come through UCSF. And we are going to publish this series very soon. And with the remainder of my time, I'm just going to talk about how we're utilizing our wealth of data to answer key questions that have come up over the past 5 years about active surveillance, and really just the power of this database that we've put together. And one question that is frequently brought up is for patients that have grade group 1 prostate cancer, but they have a lot of their prostate with grade group 1 disease, is active surveillance safe for these patients? And the reason why we wanted to study this was because in the guidelines specifically, there are asterisks around active surveillance for these patients. And the asterisks basically say patients with high volume, low grade disease may benefit from definitive therapy, either surgery or radiation. And because of that, clinicians really just are very hesitant to prescribe active surveillance for high volume disease. And so we wanted to look at that in our cohort. And fortunately, our data is, we have a lot of patients who early on underwent radical prostatectomy for diagnosed grade group 1 prostate cancer. And obviously, this is not the way we manage patients now, but we have a lot of data that can inform these decision points in the current era. And the outcomes that we looked at for this study were upgrade at RP. So in the RP specimen, was there a grade group 2 prostate cancer or greater? We looked at adverse pathology. So this was major upgrade at the time of prostatectomy, or upstaging, or nodal disease. Oops, excuse me. And then recurrence, which in the study we defined as either biochemical failure or progression to salvage treatment. We had 1,000 patients who underwent prostatectomy for grade group 1 prostate cancer, which is just powerful to think about. But this is the results of the Cox multivariable hazards regression model, and I'm just going to highlight the key component of that just for the sake of time here. But our results and our finding was that increased tumor volume based on biopsy was associated with upgrade at radical prostatectomy, but was not associated with adverse pathology or biochemical recurrence after radical prostatectomy. And adverse pathology and biochemical recurrence we all know to be the more clinically important of the 3 outcomes. So we sort of published this paper, and we do say that we do believe strongly that active surveillance remains safe in this population of patients. This next project is really interesting, and I really wanted to highlight Howard Walensky here, who some of you know, but if you don't know him, he is a prostate cancer patient. He is a patient advocate and is a really well-known journalist in the field of cancer and prostate cancer specifically. And over the years, we've developed a close friendship, just talking about key questions in surveillance and prostate cancer. And he wrote this great op-ed in MedPage about whether older prostate cancer patients can actually just stop active surveillance. And really interestingly, he used his own case of prostate cancer as an example. And he's a 76-year-old male with 1 core of Gleason 6 diagnosed in 2010, with multiple negative biopsies since. And so this is his own story. And what he did was he pulled 16 experts in the world of prostate cancer, including Dr. Carroll, Dr. Cooperberg here at UCSF. And what he sort of published was that all recommended some form of de-intensification of surveillance and minimizing biopsy, but did get a lot of heterogeneous responses. 44% of people that he polled recommended continuing surveillance, and 31% actually recommended stopping surveillance altogether or moving to like watchful waiting, which is a different protocol that is less intensive. So we looked at this study in particular, and we with the rationale that many men do not progress on surveillance for many years. And importantly, the guidelines, NCCN, AUA, EAU, none address the concept of de-escalation. We looked at patients with grade group 1 prostate cancer with multiple biopsies on surveillance, and importantly, had no progression on active surveillance for the first 5 years. Our outcomes were 10, 12, 15-year upgrade-free survival, major upgrade-free survival, active treatment-free survival, and then we looked at metastasis and survival outcomes as well. And just kind of like with the other studies, we had 774 patients. I'm introducing the life table estimates here. Of note, these numbers are flipped from the last two life tables that I displayed, because this is survival. And so just to look at the 15-year outcomes, for example, even in this low risk cohort of patients who didn't progress over time, almost 79% of the patients did have an upgrade event. And so again, these are flipped. 39% of patients in that cohort at 15 years had a major upgrade event. And again, metastasis was low, 2% in the cohort, and essentially no patients had a mortality event. And so, again, we've just found that, high upgrade rates, low rates of metastasis mortality. But, the key takeaway for us was that, patients shouldn't stop surveillance, even if they don't have upgrade early on in their trajectory. We also looked at other factors that were associated with risk of upgrade and major upgrade. I won't go into those multivariable models here for the sake of time, but the takeaway, was that it does suggest a role for continuation of active surveillance in patients that don't progress, and suggests that you can de-intensify potentially in patients that have, for example, lower PSA density or lower core positivity. And then really quick, I know I'm a little over time. I'm going to talk about genomic testing and surveillance. And we just published this series in our database looking at patients with Decipher testing and how that can inform active surveillance. And so genomic testing has exploded over the past few years, but none of these tests were designed in an active surveillance population. Most of them were designed to assess surgery outcomes, but are frequently used for surveillance. So we looked at that. And just to skip over this, we did use a high risk cutoff for Decipher at 0.6. And we looked at upgrade, major upgrade, and the development of unfavorable histology on subsequent biopsy, which we believe to be an important outcome. We identified 500 patients that had Decipher testing and were on active surveillance. A lot of data here, but I'm just going to highlight sort of the key takeaways is that Decipher was significantly associated with major biopsy upgrade. So progression to grade group 3 or higher, and progression to expansile cribriform or intraductal carcinoma pathology, which are considered adverse pathologic features. And we controlled for CAPRA, which is a well-known preoperative risk calculator, and as well as we did another model that used preoperative characteristics. And then just our takeaway is that Decipher may be beneficial in this cohort. This is a single institution study, so obviously we need to do further work on a national level to validate this, but we believe Decipher to be useful, at least in our patients, and we use them currently. So lots of things that we're interested in looking at. How does AI have a role in surveillance? Can we use it on digital histopathology, for example, Artera being the test that we're currently looking at. The Decipher grid, so every patient with a Decipher test has basically has full transcriptome data as well as additional pathway data associated with it. We're trying to see if we can fine tune Decipher testing for active surveillance to improve risk stratification. How does focal therapy play a role in surveillance? Can it be used to prolong patients' courses on surveillance, and what's that going to look like, and what are the protocols going to be in the next few years? And then identifying biomarkers for non-progression, and how can we optimize de-escalation protocols. And then, just really shout out again to Howard. He's plugged me into patient advocacy groups. ASPI is a big one. The Active Surveillance Patients International, probably the largest active surveillance patient advocacy network that I've been a part of. And then he also has a journal that I occasionally write for. And shout out to Howard, who's plugged me into all these groups, and for our friendship. I just like to acknowledge my family, Helen, who's just supported all of us really, and Lucas is my 2-year-old. The prostate cancer team, my direct mentors, Dr. Carroll, Dr. Nguyen, and Dr. Stoller. All the people that I've worked with over here. There's Janet, who's my partner in crime, and that's us at EAU. And to our patients. So thank you for your time.
All right, well, we are at time, so I'm going to close our session today, but excellent job, Mika, Jorge, Kevin. Thank you all so much. You set a fabulous example for everybody in the room, and we appreciate everything you do, and we're very proud of you. So thank you.